Thank you. It is a great delight to really participate in this meeting, but I actually, with a lot of trepidation when I was given the title of the talk. To quote Niels Bohr, prediction is very difficult, especially it's about the future. And why would he pick me to talk about the future? I would be the perfect person to talk about the past of our society because I was there from day one. I was probably one of the very few people in this room who can say that I actually perform AMO and interpret AMO, only AMO. My training goes back to the AMO days. So I would be the perfect person to talk about the past. Why was I picked to talk about the future? I think after some careful consideration, I think I know why. Because I am this guy. Oh, what happened? I'm moving the mouse too much, probably. So I'm this guy. I'm not a computer geek. So what I hope I would do is that I have lived through a lot of changes in the field of echocardiography. I hope I will give you a simplistic but also realistic kind of look into the future of echo. So with that as an introduction, let's see what we're going to expect in the future. Well, I don't know how many of you know this date. You know, May 23rd, 2017 is a very auspicious day. It's a very important day. Any people know why? And that's the reason. That's the day that the world's best Go chess player was beaten by Google's AlphaGo computer system. Now, to put it in perspective, Go chess has a board of 19 by 19. The top players can think, at least reported to be able to think 50 steps ahead of the person move. So it's been predicted, because it's so complicated, that no computer system will beat the top Go chess guy for another 10 years. And yet, Google's AlphaGo did it with artificial intelligence last year. Now you would say, well, that's chess. What does it have to do with we people in the medical field? Well, let me show you what is happening in the medical field. This is a paper that just came out in the Journal of American Heart Association. What they have done is this. They use an iPhone with a specific software. So they take a 3 20-second picture of your face, and they can tell you with very high reliability whether you're in atrial fibrillation or not. So they tested it in 217 patients, a third of them atrial fibrillation. You say, how do they detect it? They detect it by the subtle change in the facial color that is responsible by changing in the pulse volume. Isn't it remarkable? That is reported. That's here now. So we should be worried. We should be worried. Now, to put it in perspective, we really have to talk about some of these terms so that we know what we are talking about. Now, guys like Dr. Chow here knows what this is, but at least I would define those terms in simple terms so that we all know what we're talking about. When you say about artificial intelligence, we mean that the computer system is able to perform tasks that require human intelligence. Nowadays, when you read about artificial intelligence, there are 2 terms that you'll hear more and more. One is machine learning. The other term is called deep learning. The way I understand it, deep learning is just really a more sophisticated form of machine learning. Now, what are the properties of machine learning and deep learning? It is the ability for it to perform tasks, to be able to learn without explicitly programmed by human. In other words, the machine can come up with things that you would not have expected, because it really come back to the Go chess. That's what the AlphaGo system is. It's built on machine learning. And in the first game you play with the grandmaster of Go chess, the first 10 to 15 moves have never been played by a human before. Never been. It's very normal moves. Now humans are adopting it. Isn't it amazing that the computer can actually learn on its own and come up with moves that we never played before? That's what we are talking about. Now, the other term that we also will hear about is called artificial neural network. And this is again, a sophisticated computer term describing how the input function and output function are interconnected as modeled after the human neurons. What it means is that all the different neurons are interconnected in multiple layers. That's as far as I can go. Don't ask me any more than that. So anyway, it's a very sophisticated way to allow the computation system to come up with patterns, to identify patterns in really, really very complex situations with multiple variables. So those are the terms that you hear about, that is artificial intelligence, machine learning, deep learning, and then of course this ANN, artificial neural networks. Should we be worried? Well, you know, there's one specialty that's much more affected than we are. Which specialty is that? Radiology. Radiology. Why? Because radiology is largely an image analyzer. What would be better in analyzing an image than a computer, than a sophisticated computer, right? So it's very logical to think about it. And this is really the publication, you can see the publication in radiology from 1972 to 2017. There has been exponential increase in publication in radiology that contain the word of computer-aided diagnosis, machine learning, deep learning. So we better get used to it. The computers are coming. We had to adopt to it. We had to adopt it. Now, when in the radiology world, when we talk about computer-aided diagnosis, what do we mean? Let me show you an example. This is an example of phenotyping mass in the breast. Is it tumor? Is a mass nodule in the breast? Is it tumor or not? What do we look at? So this is one situation. You use computer to help you in terms of phenotyping the mass. And you can see now, being a radiologist, you can program in parameters for the machine to help you. And parameters such as size of the mass, the shape of the mass, the morphology of mass, and then there are additional sophisticated aspects that your eye may not be able to see that you can program the computer to do. That is, you can look at the texture, you can look at how the enhancement curve changes, and you can also look at different other aspects as well. So a computer can really phenotype a tumor mass or a mass in the breast in a much more quantitative way and precise way than human. Not only that, remember what we talked about machine learning? In addition to just programming the algorithm that you know the feature that are important, that is size, shape, and all that sort of thing, with machine learning is that the machine learning can detect features that you never thought before. And that's illustrated on the right side of the screen. So combined with machine learning, you not only can look at the phenotypic variables that you know of, you're also able to come up with new variables that may be very important, not just in the diagnosis, but in the prognosis. And we are not talking about the future. We are talking about in breast cancer, it's here now. And they are talking about this for chest x-rays, for CT scan of the head. So the implications are really obvious. The positive implications are listed here, right? With computer-aided diagnosis, you can improve the diagnostic accuracy. We think using that you can improve the quality of the images that you're going to get. And the very exciting thing is that the machine learning may be able to extract information that's not apparent to your naked eye. That's really a very amazing opportunity, isn't it? Think about it. The machine can also, using a computer machine learning program like this, you can also have the machine to screen, let's say, 100 chest x-ray, right? Like they are doing with ECG tracing now, right? I'm sure many of you, ECG, you look at the computer reading and you say, agree. That can be done for chest x-ray, that can be done for mammogram, that can be done for CT scan as well. So we save time. By saving time, you can also improve the timeliness of your report that Dr. Sanfilippo will talk about. We can turn around report quicker. We can also be more efficient and reduce cost. But every positive side has a flip side. The radiology field is actually very worried. Why? When you talk about more efficient, meaning you need less people to read the scan. When you're talking about less time to do the procedure, you will reduce the cost. The way things are going, the field of radiology may be very different compared to what we perceive now. Now, here is a couple of quotes, right? The first quote is in the New England Journal of Medicine, and it said, machine learning will displace much of the work of radiologists and anatomic pathologists, because those are imaging analyzers. So for echocardiographer now, if we are nothing more than just image analyzers, we are going to be in trouble too. Think about that carefully, right? And then the next quote is that machine learning will become a powerful force in the next 5 to 10 years and could end radiology as a thriving specialty. That comes from 2 world-renowned radiologists. Think about that. So the upside has a flip side. And we have to be mindful of the flip side. And in fact, the Journal of American College of Radiology developed the whole issue, the whole March 2018 issue, this current issue, on nothing but data science, big data, machine learning, and artificial intelligence. To prepare for this talk, of course, I have to read the issue from front to back, right? I'm telling you, the fear is in there. You read the journal, the fear is very apparent. So we better be prepared. We better be prepared. We should be more than just an image analyzer. So what is echo? Let's boil down the essence of echo, right? So let's see where we stand. How is computer technology, deep learning going to replace us? We better be prepared. So I'll break that down to my way of thinking. There are 4 components. 1, you need to acquire the image. And generally, it takes about 30 minutes to 60 minutes. And you have to acquire the multiple views that we talk about. 2, the image needs to be processed. The measurement needs to be done. And depending whoever done it, it takes about 10 to 20 minutes. And then it has been interpreted and reported. And I think my numbers are actually quite close to what Dr. Sanfilippo put in. When you look at interpretation and reporting combined, we are talking about anywhere between 15 to 30 minutes, right? That's what he quoted as well. Now, could this artificial intelligence, this machine learning, impact on these 4 essential components? I'm telling you, it already has impacted. You may not have noticed it, but it already has happened. It already has happened. Let me show how it's happened. This is 3D. You all have seen it. And you can see that in the, let's see. Okay, I move it slowly. Okay, and this is a 3D volume that is cut in, basically in just half, showing you that you can see into the left ventricle. This is left ventricle, left atrium. Of course, this is right side. What I'm saying is that 3D is here to stay, and it's only going to get better. Think about it. If you can just get a 3D volume from the peristernal window, one 3D volume from the apex, right? And use that, you can then, and this is an example from the apex, you can then use to segment the volume into your 4-chamber view, your 2-chamber view, and actually in your short axis view. So instead of doing all this multiple images acquisition, for the peristernal and the apical, you need only 2. And that is already here, right? But the image is not quite there yet. But the technology being the way it is, artificial intelligence being the way, advancing the way it is, I am pretty sure this will come. So it will impact on image acquisition. In other words, for sonographer in the audience, better get used to 3D because it will make your life easier. You will not have to spend that 30 to 60 minutes that Dr. Sanfilippo talked about to do the entire study. You really, for the most important views, you only need 2 volumes, 2 good volumes. And it's already emerging here. So I'm not talking, this is really very close. Now, I also talk about the issue of processing and measurement. There's a lot of automatic edge detection algorithms out there. This is one that I quote, and I think Dr. Wendy Sang probably is much more expert in that than I do to talk about it. But this is the hot model way to measure LV volume and ejection fraction automatically. Think about if this is reliable and proven to be robust. Think about how much time you save in terms of the measurements, in terms of trying to process the images. This is already here, right? It will only get better. It will only get better. So we better prepare for this. We better prepare for this. And in terms of reporting, I think let me say one word about reporting. The radiology people have been looking at the reporting. One thing, the most important thing they can improve your report is what? Using a structured template. A structured template with multiple subheadings that cover all the structures. And in this study from radiology, it showed that if you use a structural template, your report will be more comprehensive. You're not going to miss findings. So in this particular study, if you don't use it, you just dictate, you will only remember the most important thing. You miss the cancer in the peripheral zone. Same thing in echo. And I think I have looked at some of the reporting from other centers. Things that you miss, right? It's so obvious. So I would say for those labs that has not been using a structured reporting template, please consider doing it. It will force you to look at the individual component more comprehensively, and you will have a more comprehensive report. That's already here. That's already here. We should use it. We should use it. So I already talked about how machine learning and artificial engineering has already impacted on image acquisition, on processing and measurement, and also on reporting. What I haven't talked about yet is how would machine learning impact on the interpretation process itself. So let's then quickly show you some data on that. The group in Mount Sinai is at the forefront of this. Now in this particular study, they basically look at using machine learning to predict the left ventricular relaxation abnormality. And then this particular approach is called continuous wavelet-based time frequency analysis. What it does basically is to plot the ECG, using this particular program, to plot the ECG in terms of its frequency, timing, and energy, which is really kind of this particular scheme is supposed to show. These are high energy, the bright color. The darker color is low energy, okay? And they show the corresponding tissue Doppler. What it shows is that using machine learning that look at 370 features of the signal processing EEG, they can predict the average E prime velocity with reasonable accuracy. Isn't it amazing? 370 features. And the idea is that, if this is proven to be robust, you can use it as quickly as a screening tool to pick out people who require a detailed echo Doppler study. Isn't it amazing technology? Now, you say, wow, that's still a little bit abstract to me. So this is another study from the same group. In this one, they also use machine learning, but the concentration is mainly on looking at the speckle tracking signal in the apical four-chamber view. And they ask a much straightforward and simple question. They say, can we tell athletic heart from hypertrophic cardiomyopathy? And you can see that basically they then further split them into those younger, older, those who are thicker wall versus those with less thicker wall. So they result in on the next slide. And you can see now with their approach, with machine learning, largely based on the spectral Doppler information, they can predict, they can differentiate hypertrophic cardiomyopathy from athletic heart quite reliably. Now remember though, this is a simple one answer question, meaning is it this or that? right? They are not applying to a wide spectrum of heart disease. You say, well, gee whiz, this, when you see a patient, it's never one issue, right? It's a spectrum of issues. The patient can have aortic stenosis, but also can have amyloidosis at the same time. It's never one thing or the other. How do we approach that? The interpretation process is a little bit more complicated than that. And I've been looking for a way to describe our cognitive process. How do we approach the interpretation? So here is how they define it from the Mount Sinai group. And they say, a trained eye often automatically integrates multiple attributes of interest in a moving image without statistical reasoning, and these perceptual cues jointly contribute to clinical differentiation patterns. That's how I define it. And I don't agree. Because you define it that way, it's not teachable. It's not learnable. You have to be able to teach. You have to say, if this is that, the trainer, you look at me and say, why do I say that? If I cannot tell you why I say that, that's not a teachable thing. So this is not the correct way to define the interpretation process. I would look at it differently. I will look at it this way. I think in echo, we are really unique in the sense that the interpretation requires not just the cognitive expertise, but it also requires the technical procedural expertise. In our lab, for instance, right, if our technologists, I have some of our technologists here, you can check with them to confirm that I'm telling you the truth. If they have problem with certain unusual case, the echocardiographer should have the technical ability to go in, get unconventional views, get unique views to answer the question. That is what I mean by procedural expertise. I agree with Dr. Sanfilippo. You cannot be a good interpreter of echo without a technical skill. You have to be good in that. And that's also important in terms of teaching and interaction with your sonographer. You cannot do that, I don't think you can interpret reliably. And second thing, I think nowadays we are beyond just pattern recognition. I think we need a very good anatomic conceptualization of normal heart and the pathologic heart. Particularly when we move into 3D, how we segment the ventricle. It really hinges on how good a conceptualization you have with the cardiac anatomy. And that's the key. And of course, with Doppler nowadays, we also need to have a very sound base of the physiological principle that drive blood flow. And with all that, you obviously need to integrate all these attributes, right? And of course, we need statistical reasoning. How can they say that you don't need to? For instance, I'll give you an example. If you have multiple masses in the left ventricle in an infant, you don't, versus someone in a 65-year-old smoker, you don't say they are the same thing. The former is much more likely to be rhabdomyoma, while the latter is much more likely to be metastatic cancer. That is statistical reasoning. Of course, you need to apply that. So the way I think about it, there's a lot of skill involved in the interpreting process. The way machine learning now are still not at that stage. The machine learning now, as I read the literature, is very good in simple, straightforward, rule-based questions. In other words, you have a lump, is it cancer or no cancer? I think we are still reasonably safe right now. So how do I see it? I would say that the echo very soon will be simpler to do, I hope. The image acquisition will be cut down by half. The processing time will be cut down by half. The reporting time, if you use a structured template, will be shorter as well. The interpreting process, I think, remains to be seen how it's going to evolve. So the bad news is the robots are coming. They're coming to get you. Make no doubt about it. I'm sure of that, right? The radiologists are worried. We should worry a bit as well. But the good thing is, I think the good news is the robots are coming, but they are going to do most of the routine, mundane work. And I think if you approach our profession properly, we'll still have a very exciting future and very interesting work to do.